What I'd like to do is share with you a study that was published last year by our group, and it's a preclinical study in a canine model. And here the objective of the study was to compare two types of implant designs, a bone level implant with a bone level tapered implant, so a parallel walled implant with an apically tapered implant, into immediate extraction sites. And here we use the maxillary second incisor sockets in the dog model, which is more closely, I think, relatable to what we see in a clinical situation when we place implants in the anterior maxilla. Now, ISQ was used to measure the stability of the implants at the time of placement, and that was the primary outcome measure. But we also looked at histology, which is really what I want to show you for this study today. So here is the study design. 9 pairs of maxillary second incisors were used, so contralateral, and randomly selected for either a bone level tapered or a standard bone level implant. The teeth were carefully extracted with a flapless extraction technique, ensuring that the facial bone was not damaged at the time. And then the implants were placed according to the manufacturer's instruction, taking care that the facial aspect of the implant shoulder was at that facial bone crest. So typically of what you would do clinically when you place an implant immediately into an extraction site in a maxillary anterior region, and you're attempting either immediate loading or a delayed loading protocol, but the positioning of the implant would be similar. And at the same time, ensuring that a 2 millimeter gap was maintained between the implant and the internal aspect of that facial bone. And into that defect, deproteinized bovine bone mineral was grafted, and this was in a collagen sponge, and then the graft was protected and sealed off with the manufacturer's 3D collagen sponge. And this was then allowed to heal for 12 months. For 12 weeks. Now, at the time of implant placement, ISQ was done, and it was shown that the mean ISQ for bone level tapered implants was significantly greater than the ISQ for bone level implants. And so it was 66 versus 60, so a 10% difference, which was highly statistically significant, leading to the conclusion that implants with an apical taper into an immediate extraction site achieve higher initial stability than parallel walled implants. Okay, so that was the primary aim of the study. But as I said, the histology was what was very interesting and pertinent to what we're talking about with post-extraction healing. So after 12 weeks of healing, what you can see on the histological image on your right-hand side is the tapered implant, and the green illustrates the biomaterials or the deproteinized bovine bone material. And you can see that this is now the regenerated facial bone consists almost entirely of the biomaterial or the bone substitute. Now, what you also will see is that the facial bone crest, and remember the implant was placed initially with the implant shoulder at the level of that facial bone crest. You can see that there's a vertical resorption of approximately 1.5 millimeters. So the immediate implant placement and the grafting did not stop the vertical resorption of the facial bone according to the bundle bone hypothesis. In addition, the width of the residual bone crest, and remember the implant was placed 2 millimeters from the facial bone crest, and that was grafted. But that showed a resorption or horizontal resorption leading to the residual ridge of about 1.4 millimeters in orofacial dimension. So the original 2 millimeters had reduced to 1.4 millimeters. Once again, demonstrating that in the early phase of healing, there is a vertical and horizontal reduction in the dimension of the ridge, even when a bone graft has been placed.